Welcome to Healing Horizons. I am Chris Daniels, your host, and today we are exploring Ibogaine therapy for veterans living with anxiety disorders and trauma. This is a professional, compassionate look at how a powerful, non-conventional treatment offered in Mexico may help when standard care has stalled. We will unpack what Ibogaine is, how it might work in the brain and body, who might benefit, who should not, and how to approach safety, preparation, dosing, and integration. You will also hear practical guidance for coordinating with existing providers, navigating clinics, and building a recovery plan that respects military culture. My goal is clarity without hype, honoring both the promise and the limits so you can make informed, safer choices, grounded in evidence and empathy. Let us start with why veterans carry distinct mental health burdens. Combat exposure can drive post-traumatic stress, but the picture is broader. Many live with moral injury, the pain of actions or losses that violated core values. Traumatic brain injury and blast exposure can amplify irritability, memory problems, and sleep disturbance. Chronic pain and musculoskeletal injuries are common, feeding anxiety and depression. Nightmares, hypervigilance, and insomnia erode resilience. Stigma about seeking help persists, and time-constrained care can default to stacked medications. Polypharmacy brings side effects, interactions, and emotional blunting that may worsen isolation. Alcohol or opioid use can become coping strategies. Family transitions, loss of unit cohesion, and challenges with civilian identity complete the load. Any intervention must meet this complexity respectfully, always. Ibogaine is a psychoactive alkaloid from Tabernanthe iboga, a shrub native to Central West Africa, used in Bwiti initiation and healing ceremonies. In the 20th century, it drew attention for interrupting opioid withdrawal, and in recent decades, it has been applied in clinical-style settings, especially in Mexico, where it is not scheduled nationally. Unlike classic psychedelics such as psilocybin or LSD, Ibogaine is a onirogenic compound. Experiences are often dreamlike, with vivid autobiographical sequences and somatic intensity. The acute phase can last 24 to 36 hours, followed by a lingering afterglow as Ibogaine circulates. Many people report reduced cravings, improved sleep, and a reset of maladaptive patterns. It is potent medicine, neither a magic bullet nor a casual experience for any participant. How might it help anxiety and trauma? Pharmacologically, Ibogaine and its metabolite noribogaine act at multiple systems. Noribogaine inhibits serotonin reuptake, increasing synaptic availability in a manner reminiscent of SSRIs, yet with a different time course. Ibogaine modulates NMDA receptors, which may disrupt entrenched cue associations and support relearning. Activity at kappa opioid receptors could dampen dysphoria and stress responsivity. Early work suggests neurotrophic signaling, changes that may enhance neuroplasticity. Clinically, people often describe revisiting pivotal memories with reduced avoidance, extracting meaning rather than spiraling. This may touch fear memory reconsolidation, where salience shifts and physiological arousal softens. None of this is proven with definitive trials, but the converging basic science helps explain why some veterans notice less hypervigilance and improved emotional flexibility after treatment. Where does the evidence stand today? The strongest published data concern addiction interruption, particularly opioids, with reductions in acute withdrawal and short-term craving. For PTSD and anxiety, we mostly have observational cohorts, case reports, and qualitative interviews from clinics in Mexico and elsewhere. These suggest improvements in sleep, startle, irritability, and rumination for some, often within weeks. However, there are clear research gaps. Randomized controlled trials are scarce, patient selection varies, and long-term outcomes depend heavily on integration and environment. Safety profiles also differ by clinic protocols. The responsible stance is cautious optimism. Ibogaine shows meaningful potential, but we need rigorous trials, registries, and transparency so veterans and families can weigh benefits against risks with real-world data shared across clinics and time. Who might benefit? Veterans with treatment-resistant anxiety or PTSD, especially when accompanied by entrenched patterns like hyperarousal, nightmares, avoidance, or co-occurring substance use, may find Ibogaine worth exploring within a medical framework. Who should avoid? Anyone with structural heart disease, a history of dangerous arrhythmias, prolonged QTC, uncontrolled hypertension, significant liver disease, active seizure disorders, or pregnancy should not proceed. Sleep apnea, severe anemia, and recent stroke or cardiac surgery call for extreme caution and specialist clearance. Older adults, or those with complex polypharmacy, require additional review. Ibogaine is not a first-line therapy. It is a potential adjunct or alternative for those who have tried conventional therapies conscientiously yet remain impaired, and who can commit to robust aftercare with sustained support structures. Medications matter greatly. Ibogaine can prolong the QT interval and interact with drugs that also stress cardiac conduction or serotonin systems. Careful supervised tapers may be needed for SSRIs or SNRIs, tricyclics, MAOIs, and many antipsychotics. Methadone significantly increases risk. Transitioning to short-acting opioids and stabilizing before detox-based protocols is common. Buprenorphine requires strategy and time. Benzodiazepines should be addressed thoughtfully to reduce withdrawal or rebound anxiety during treatment. Each taper is individualized, often over weeks, to minimize destabilization. Coordination with prescribers is essential, and abrupt stopping is unsafe. Supplements and over-the-counter agents can matter too, especially antihistamines, dextromethorphan, or St. John's wort. Baseline EKGs, electrolytes, and liver panels guide decisions, and timelines should favor safety over speed for every veteran. What should safe care in Mexico look like? Reputable clinics begin with comprehensive screening, medical history, medication review, physical exam, baseline labs including electrolytes and liver enzymes, and a 12-lead EKG with QTC assessment. Cardiology consultation is obtained when indicated. During dosing, continuous cardiac and pulse oximetry monitoring should be standard, with frequent blood pressure checks. Staff must be ACLS trained, with defibrillator, airway equipment, IV access supplies, and emergency medications on site. There should be a written emergency transfer plan to a nearby hospital, verified ahead of time. Informed consent should cover risks, alternatives, and data sharing. Dosing is paused or deferred for abnormal findings, not negotiated. Safety culture values conservative decisions, clear communication, and transparent reporting of outcomes before, during, and after. Clinics use several dosing strategies. A test dose assesses sensitivity and reveals early cardiac effects. A flood dose, usually weight-based, produces the primary therapeutic experience, sometimes delivered in divided increments over a few hours. Boosters may follow days later to consolidate gains. For addiction detox, protocols emphasize withdrawal suppression and may integrate comfort medications. For anxiety or PTSD without active dependence, dosing often targets insight and memory processing with slightly lower totals, longer preparation, and more psychotherapy support. The experience can be physically taxing, so hydration, electrolyte management, and gentle movement afterward matter. Not everyone needs a large dose. Clinical judgment, age, medical status, and goals guide decisions. Quality programs personalize the arc rather than applying a single template for safe, meaningful change together. Preparation is a clinical and psychological process. Secure medical clearance, complete informed consent, and map out medication tapers well in advance. Establish trauma-informed plans for grounding, communication, and privacy. Set intentions that are specific and flexible, such as sleep recovery, reconnection with family, or releasing guilt. Build a support network that includes a therapist, peers, and loved ones who understand boundaries. During sessions, veterans often report vivid life reviews, encounters with symbolic imagery, and somatic waves that unfold in phases. Afterward, common shifts include less reactivity, easier sleep initiation, reduced nightmares, and a window of motivation to change routines. Outcomes vary. Some feel lighter immediately. Others need weeks of structure before benefits stabilize. Patience and continuity carry the gains through daily practices and accountability. Integration is where healing becomes durable. Plan structured aftercare for 3 to 6 months, with weekly therapy oriented to CBT, EMDR, or somatic work, plus peer support and routines around sleep, exercise, and nutrition. Build relapse prevention for substances and emotional relapse signs like isolation or avoidance. How does this compare to standard care? Medications such as SSRIs, SNRIs, or prazosin, and therapies like CPT or PE help many veterans and remain first line. Ibogaine should be viewed as an adjunct or alternative when those avenues have not delivered adequate relief, or when a reset may unlock stalled progress. It can catalyze change, but behaviors, relationships, and community secure the long-term results. Track sleep, mood, and triggers objectively to reinforce momentum between clinical visits. To close, a map of Mexico's landscape and your next steps. Ibogaine is not scheduled federally, yet clinic regulation varies, so ethics and transparency matter. Vet programs for physician oversight, rigorous screening, continuous monitoring, emergency readiness, and outcome tracking. Special cases like traumatic brain injury or sleep apnea need neurologic review and CPAP. A realistic arc is 4 to 8 weeks of preparation, 24 to 72 hours of acute care, 2 to 6 weeks of stabilization, and 3 to 6 months of integration. Coordinate with the VA, your therapist, and family. Seek veteran nonprofits, scholarships, registries, and community groups. Avoid polysubstance use, correct electrolytes, and secure post-treatment supervision. We covered challenges, mechanisms, safety, and integration to support safer choices. Thank you for listening.